He's also investigating ways to improve current therapies for prostate cancer and develop new therapies to treat advanced prostate cancer. Drs. Gulley and Maiden, thank you for joining us today.
Great. Thank you, Brian. So I'll get started, and I appreciate the introduction, Brian. The concept that the immune system can actually be important in defending the body against cancer is actually not new and has been around for well over a century. There was originally put forth a concept of immune surveillance, which suggested that just as the immune system patrols the body and fights off infections, it may actually do the same thing in fighting off cancer. And so this schematic highlights how that may be possible. We see here immune cells and then the body's normal gray tissue, and these little orange cells are essentially rogue cancer cells that can develop over time. The immune cells here above are able to recognize the cancer cells and basically eliminate them as they pop up. Unfortunately, for reasons we don't fully understand, the immune cells can get overwhelmed, resulting in proliferation of these cancer cells and the development of a larger tumor. Now, the cancer cells are actually not bystanders in this process. They've actually been able to manipulate biological mechanisms to enhance this process. And our understanding of that over the last few decades has helped us to develop newer therapies to combat cancer with immunotherapy. Early immunotherapy strategies were actually relatively primitive, using cytokines or chemicals that the immune system used to communicate within itself or with each other at high doses given to patients to try to stimulate an immune response. BCG is a modified bacterium that has been instilled in the bladder to really generate a non-specific immune response to improve outcomes in that cancer. And primitive immunotherapy strategies actually employed injecting proteins just under the skin with hopes that with hopes that the patient's immune system would recognize that protein as being similar to one on a cancer cell and using that mechanism to destroy the cancer cell. These strategies have had some modest successes, but have given way to more modern immunotherapy strategies, which are really divided into two categories, which we'll focus on for today's discussion. Therapeutic cancer vaccines are designed to enhance basically immune recognition of cancer cells and leading to their targeted destruction. Immune checkpoint inhibitors are slightly different in that they basically are designed to diminish the immune system's control mechanisms, thereby allowing the immune cells to go a little bit more hyperactive or crazy, hoping that some of those hyperactive immune cells will then take out cancer cells. Therapeutic cancer vaccines are the first modality we'll focus on, and again, they're designed to generate a targeted immune response against the tumor. And it's important to note that they're associated with minimal toxicities. And because they're actually stimulating an immune response and having the immune system actually attack the cancer, this actually results in a more delayed effect than we're seeing with conventional cancer therapies that actually directly kill cancer cells. But the other thing that makes it very different than standard drugs is that unlike a drug, when you take it and it's out of your system, it no longer has an effect. Immunotherapies may actually teach the immune system to fight cancer, and in that way, they may have a prolonged benefit even after the period of administration.
So I'm going to pick up here, and I'm going to talk about the very first approved therapeutic vaccine for any cancer, and that was approved in prostate cancer. This is called Sapulosal-T or Provenge. What happens with Provenge is you first go to a physician's office, you get evaluated, and if you are eligible for this, then you're sent to a center where you get your blood taken out. This blood is goes through a machine that takes out more of the white blood cells, the cells that can fight infection and fight cancer, and then gives you back the rest of the blood product, the red blood cells and the platelets and the plasma. These white blood cells are then sent to a central processing facility where they are pulsed with a protein called GM-CSF, which helps stimulate an immune response, as well as PAP, which becomes a target for those immune cells. PAP, or prostatic acid phosphatase, is found in prostate cells and can be a good target for the immune system. This then is sent back to the doctor's office where this product is then infused into the patient. This entire process is repeated 3 times over the period of about a month for a complete treatment course. This is the data that the FDA used to approve Sapulus LT. What you can see here is that there was in yellow you see the overall survival of patients getting the Sapulus LT versus control. And so there was an improvement in overall survival that was on average 4 months. This was associated with about a 22% reduction in the risk of death. I'd also like to mention that we have a vaccine that we've been testing here at the National Cancer Institute and elsewhere. This is the ProstVac vaccine that you heard about earlier from Brian. It is a vaccine that is designed with a virus backbone, and in that virus you have the insertion of several things. First, you have PSA, which is a tumor-associated antigen gene that becomes the target for the immune cells. And then you have other genes that help really boost the immune response. These are called co-stimulatory molecules. This can be simply grown up in large quantities, these viruses, and then injected into patients. Basically, the pharmacist just has to take this off and out of the freezer shelf and thaw it and inject it into patients. Once a virus gets injected under the skin, it will encounter antigen-presenting cells. As you can see here, these are really the teacher cells of the immune system, and these will then teach these T cells to recognize and be able to attack the cancer. These T cells can then travel anywhere in the body that there is tumor and kill the cancer. And we'll talk more about that in a little bit. So we've done multiple different studies with this ProstVac vaccine. This is just some of the results of the earlier studies, 6 different trials with about 150 patients, and you can see that it is very well tolerated. Very few patients have any adverse events, and you can see here that the majority of patients, or many patients, do get injection site reactions. However, there's very few, on the order of 0.1 to 2% of all of these other types of effects following the vaccine, and generally these are quite mild. Now, another immunotherapy type that has been tested in prostate cancer is immune checkpoint inhibitors. They have some characteristics similar to vaccines. You can have some delayed effects seen, some of the clinical responses aren't seen right away, and they can have impact long after the immune checkpoint inhibitor is given, just like vaccines. However, unlike vaccines, they can really generate a non-specific T cell activation so that you can get immune responses to normal targets rather than just immune responses to the tumor, and so you can get autoimmune related toxicities, which are generally manageable with appropriate medical management. Ipilimumab is the first immune checkpoint inhibitor that was approved by the FDA, and it was approved in melanoma. We'll discuss trials in prostate cancer momentarily. But once a T cell becomes activated, this T cell will upregulate certain markers, including CTLA-4, and this upregulation of the CTLA-4 will lead to binding on the antigen-presenting cell, and that will lead to a downregulation of a T cell response. So it will turn that T cell back off. However, if you block that from happening by the use of this anti-CTLA-4 antibody here, then that T cell that was activated can remain activated and continue to have good activity. So this is the trial design of the first phase 3 trial that was presented. This trial took patients who had previously had chemotherapy with advanced metastatic disease, had failed hormonal therapy, failed chemotherapy, and taken them and randomized the patients to get radiation plus ipilimumab versus radiation plus placebo. And here you see the overall results of the primary endpoint, which was overall survival in this study. And you can see that patients who got the ipilimumab really didn't do statistically any better than patients who got the placebo. It was close. There was a trend towards improved outcomes, but you can see early on there were actually more deaths in the patients who got ipilimumab. So this did not meet the pre-specified criteria for approval. There is an ongoing phase 3 trial that has not reported out yet in the pre-chemotherapy setting in patients with metastatic prostate cancer. But I want to share with you some additional data, and that has to do with what happens to that immune response. Those immune cells, once they come into contact with the tumor and start to kill the tumor, that's really only the beginning of the story. So really what happens then is that as those tumor cells are dying, they are taken up by scavenger cells, or as one person put it, the cleaning lady. They'll come in and they'll take up these dead and dying tumor cells, and then they can present this back in the lymph nodes back to the T cells, and this can lead to a broader immune response. So instead of just having a T cell that is targeting PSA secreting tumor cells, it can now target many other different targets found within the tumor cell, and this new army of T cells can then go back and attack the tumor again. And this is something that we refer to as the tumor immunity cycle, and this can continue to get better and better over time. This can be kind of like an engine that keeps going round after round, and over time you get a broader and perhaps more clinically relevant immune response. And so we refer to this as antigen spreading or antigen cascade, where you might start out with an immune response to one target, but over time it becomes broader and more clinically relevant. So we have evidence with our Prospect vaccine that not only can we get a really robust immune response with almost 2/3 of the patients, more than half of the patients having a really nice immune response to the PSA. And this level of immune response is very similar to what you might see in patients with reaction to flu vaccine in terms of a memory response. But what's more interesting is that 2/3 of the patients had evidence of this antigen spreading or antigen cascade, the immune response to other targets not found in the vaccine, suggesting that there was good killing in the patient by the immune system, good tumor cell killing.
Okay, thank you, James. So just to shift gears a little bit, I'd like to discuss some of our hypotheses on how immunotherapy actually impacts the tumor. And as with any new therapy, it requires a new understanding of how these therapies work. And in modern immunotherapies, including treatments discussed so far, Sipuleucel-T, Prospect, and ipilimumab in metastatic melanoma, all have a common but peculiar trait in that they appeared to not work within a few months. In other words, the disease appeared to be getting worse, but over the long term, it looked like patients live longer. Now, for medical oncologists, this is very perplexing, because our therapies that we're used to using, they only work in the long term if they seem to work in the short term. So this created a lot of questions as to how is this possible. And we have a hypothesis that I'd like to share with you, and that involves basically looking at the potential impact of these treatments on the growth of these cancers. So what this schematic shows is basically the growth of tumor over time, and with cytotoxic therapies, these are therapies that directly kill cancer cells, oncologists are used to seeing a treatment initiated at this point here that then debulks the tumor for a transient short period of time, but unfortunately over time the treatment is stopped or it stops working and then tumor regrows and gets to a point to where you reach this cross where it's unfortunately no longer compatible with life. And this is what we're used to seeing with most therapies. What we're seeing with immunotherapy is different, and that is that when you start the immunotherapy here, you actually see that in the short term, things appear to get worse. And if you look at a few months later, you may think that everything's progressing and this treatment's not working. But our hypothesis is that over time, immunotherapy basically wages a war on the cancer cells that slows the growth rate and moderates it. Thereby, over the long run, the tumor grows slower and therefore allows patients to live longer despite this apparent failure in the beginning. Now, this hypothesis is supported when we look back at several older trials with Prosvac and Sipuleucel T. Now, in our line of work, unless you upfront say this is going to be the result, it doesn't meet the criteria for scientific fact. So this is just supporting data at this point. But what this hypothesis does suggest is that the immunologic impact is gradual but sustained even for a long period of time after the administration of the treatment. Now, if you believe that immunotherapies slow the growth rate of cancer over time, then starting these therapies earlier could have a much more profound impact on survival than if we started it later in the disease process when there's less time for that therapy to have an impact on the growth rate. And again, this is another focus of some of our trials here at the NCI. Now, you may want to know what happens when you combine these therapies, and we also share that question, but this is our hypothesis, and that is that you get potentially the benefits of both therapies. That is a shrinking of the tumor and a slowing of the regrowth rate of that tumor. And this could mean that you get not just improved survival, but a delay in the progression of the disease as well. And I'll discuss some trials here that are looking at that as a primary endpoint in coming slides. In prostate cancer especially, there are multiple therapies that are actually synergistic with immunotherapies. In other words, these therapies have the potential to enhance the immune response in addition to vaccines or checkpoint inhibitors. And one such agent is enzalutamide. So enzalutamide is a blockbuster new prostate cancer drug that is FDA approved for patients with metastatic disease. It has minimal toxicity and works by blocking the ability of testosterone to fuel the cancer growth. Now, our colleague here at the NCI, James Hodge, working in the Laboratory of Tumor Immunology and Biology, looked at the immune effects of this drug enzalutamide. And what he saw was that, like other anti-hormone therapies in prostate cancer, there's the potential to increase the immune cells after exposure to this drug. So this was a study done in mice that shows that the thymus, a gland in the chest that produces immune cells, gets bigger when the mice are treated with enzalutamide. There's also an increase in these T-cell excision circles, which are the byproducts of new T-cells. So in essence, what's happening here, as evidenced by this increase, is you get a production of a new army of immune cells after exposure to enzalutamide. And when you combine that with immunotherapy, that army can be charged to attack the cancer. Now, enzalutamide also has an effect on the tumor that's very important. And this is important because it improves the ability for the immune cells to recognize and kill the cancer cells. What you see here in gray are the immunologic effects on the tumor after enzalutamide. MHC1 is a molecule that is increased, as you see by this shift to the right. And what that allows the immune cells to do is to recognize the cancer cells better. FAS is a molecule that allows the cancer cells to be engaged and killed by the T cells, or the immune cells rather, and you see that that is increased as well. So basically we see here that enzalutamide increases the recognition and the ability to kill after exposure to enzalutamide. And in fact, when they looked at the ability of T cells to kill cancer cells in mice models, they saw that enzalutamide exposure increased the ability of these immune cells to kill the cancer cells. And also, when they looked specifically at human cancer cells, human prostate cancer cells, they saw the same thing. That is, an increase in the ability of the immune cells to kill the cancer cells after they've been exposed to enzalutamide. Enzalutamide is not the only treatment that enhances the immune system that's used in prostate cancer. Another treatment is radiation therapy, which at high doses can kill cancer cells, but at lower doses alters how the tumor looks to the immune system. And this is research done again by Dr. Hodge within the Laboratory of Tumor Immunology and Biology, with a radiation treatment known as Quadramet, or samarium-153. This is a radioactive treatment that can be infused through the vein and basically localizes in the skeleton to where the tumor is. So you have low levels of radiation that basically provides pain relief to patients right at the sites of disease. And this is an FDA-approved therapy to bring relief of pain from patients who have disease in their bones. This is a bone scan that shows little white dots where the cancer is on the technetium bone scan. And when we overlay the results of what happens after radioactive samarium is infused in the veins, you see that in the same places that light up on the bone scan are the same places where samarium localizes to deliver low levels of radiation to the tumor. Now again, like I showed you earlier with the enzalutamide, the low levels of radiation delivered by samarium-153 increase the ability of the cancer cells to be recognized by the immune system by upregulating MHC1 as we see here, as well as the immune system's ability to kill the cancer cells as we see by the upregulation of the Fas molecules. Other recognition molecules that are increased on the cancer cells include PSA and other prostate-specific antigens. And again, we see that after treatment with even low levels of radiation, the immune cells have a more effective ability to kill the cancer cells because of this increased recognition and ability to engage the cancer cells.
It suggests that there's not a benefit. So you can actually look, did age younger men or older men have a benefit? It really didn't.
So we're going to talk for the last couple of slides about something we refer to as immune intensification. That is combining vaccines with immune checkpoint modulation. So the initial study that led to approval of ipilimumab for melanoma showed that this in the treatment arm. This was in patients with advanced melanoma, and this is their overall survival. And it was better than the controls. But what was very interesting about this study was the fact that there was a tail on the curve here. So there was about 20% of the patients that were alive long term. And in fact, this was recently updated at a European meeting last year. And this data is now out to 10 years, and there's still 20% of the patients alive. So often what people have started to refer to this as is a functional cure. In other words, it may not have eradicated all the disease, but the patients are living healthy, happy lives. However, this is still in only a minority of the patients. So how can we improve upon this really fascinating finding to get that to be higher, to get this to be 40%, 60%, 80% of the patients having good outcomes, these very promising outcomes? And so one thing to look at is to look at those patients who are more likely to respond. So what Tom Gajewski has looked at is looking at two classes of tumors. He refers to them as T-cell poor tumors, and these are tumors that don't have an immune response. There's really not much going on, and the immune cells are growing unchecked. And those T-cell inflamed tumors, that there the immune system is clearly active, may not be completely effective, but it is engaged in the immune response. It turns out that these T-cell inflamed tumors do respond very nicely to immune checkpoint modulators, but the T-cell poor tumors don't. What's been found recently is that we can take T-cell poor tumors and convert them into T-cell inflamed tumors by giving a vaccine, so we can generate that underlying immune response for the immune checkpoint inhibitors to work. I'm going to share with you data from 2 different studies in prostate cancer, one where we gave the Prosvac vaccine alone, and one where we gave a combination of Prosvac vaccine with ipilimumab, the immune checkpoint inhibitor targeting CTLA-4. Now, what we found was that I think it's pretty reasonable to compare these 2 separate studies because the patient population was relatively similar. And you can see that here, the predicted survival based on a nomogram was within about a month of each other, 17 versus 18 months. But what you saw with the vaccine alone was an overall survival of 26 months, with 53% of the patients, half of the patients basically, alive at 24 months. When you look at the patients who got the Prosvac plus ipilimumab, what you found was that their actual survival was 34 months, and about 3/4 of them were alive at 24 months. So this suggests that if you give the combination, you may get better outcomes. Now, this leads to the potential for doing additional randomized studies to look at this, and we are in fact planning such studies in the very near future. However, anti-CTLA-4 antibodies, the ones that like ipilimumab, can really cause much more non-specific immune stimulation and are associated with significant side effects. Those antibodies, the newer generations that target PD-1 or PD-L1, they're associated with many fewer side effects. However, to date, in prostate cancer, they really haven't seen a lot of activity, and so there hasn't been a lot of interest in exploring these newer, antibodies associated with less side effects in prostate cancer. However, if you can generate that underlying immune response and then come in with these, this makes great rationale for this combination to really get a good, effective, clinically meaningful response. So in conclusion, what we've tried to share with you is that immunotherapy may exert an immune effect over a long period of time, so that probably starting earlier on in the disease course would be better, because you can then allow this immune response to be, which is potentially lifelong, to be around for a longer period of time, slowing down the tumor for a longer period of time. The second thing we've shared with you, as Dr. Madden mentioned, was that immunotherapy may actually slow down the growth rate of the tumors rather than alter the short-term progression. So it's very important when you're getting these immunotherapies not to expect your PSA to just melt away like it might with hormonal therapy or chemotherapy, but rather it will modulate the effects of the PSA over time, and that can lead to the clinical immune response that is responsible for that can lead to improved outcomes. Also, combination therapy, I think, really is the future, and we're testing a variety of different combination therapy strategies. You heard some exciting ongoing clinical trials from Dr. Madden about combining enzalutamide with Prosvac and seeing if we can capitalize on the immune changes that enzalutamide brings. And finally, the potential for immune responses to evolve to match the antigens expressed by the tumor is also quite important, and this concept of antigen cascade or antigen spreading is very key. And the final combination that I would mention is combining vaccines with immune checkpoint inhibitors. I also believe will be something that you will see quite a lot of experimentation in, and based on early studies, I think that will be quite successful in the near future. Certainly would like to acknowledge all the people